welcome everybody to tonight's public Q&A on kidney disease. You may recall at the previous meeting we had the esteemed Dr. Danovitch, who's an emeritus professor of medicine at UCLA and a world expert in kidney transplantation. And he's kindly agreed to do another session with us. The last one was very well received. So first of all, I'd like to welcome Dr. Danovitch to tonight's meeting. Thank you, Gabe, very much for taking the time to do this.
My pleasure.
I thought we would start maybe with Dr. Danovitch talking about perhaps the difference between living donation versus cadaveric donation, or any other topic that you feel would be worth starting off with, and then we'll go to questions for Dr. Danovitch after that. So again, Gabe, thank you very much for taking the time to do this.
Well, the mere fact that you nice people are on this at this meeting tells me that there are things on your mind regarding your care of kidney disease, or particularly with respect to relevance of transplantation. And that's not surprising, because this is heavy stuff. Chronic kidney disease takes a toll on people, and the decision to go forward and have a transplant is a huge one, and I can understand what it must mean to you and loved ones to go through this. So I try never to forget what it's like to be on the other side. So I kind of give you all a virtual hug, and tell you that I know Dr. Kurtz, myself, and my colleagues appreciate as much as we can what you might be going through. That's just briefly. Transplantation is the best option for the right people. Not every person with end-stage kidney disease is a transplant candidate, but everyone would benefit from transplantation necessarily. Transplantation, it's interesting, the difference between kidney transplantation and, let's say, liver transplantation, heart transplantation. In liver transplantation, heart transplantation, people are literally dying. I mean, they may die within days or hours sometimes before they get the transplant. But in kidney transplantation, what we try to do is take people who are doing well on dialysis or doing okay on dialysis, and we try to make their lives better. So I like to say that kidney transplantation, although we tend to use dramatic terms like life-saving, I like to say that kidney transplantation is life-enhancing. We enhance people's lives. We try to make them better. And most of the time, if we get it right, we make people's lives better. Not all the time. It's not perfect. It's not mathematics. Most of the time we get people, we improve, we're able to improve people's lives. So the whole process involves determining whether a given person is appropriate for transplantation, if there are other risk factors that make it inappropriate, or whether or not we think transplantation is the best option for them. But I can say, I think with fair certainty, that if transplantation is the best option, then it's basically always better to get a transplant from a living donor than from a dead person. First of all, from the simply practical aspect of the fact that the waiting time to get a transplant from a dead person is measured in years and years. It varies around the country, and I can talk about that separately if you like. But in all of Southern UCLA and basically all of California, North and Southern California, from San Francisco to San Diego, waiting times are measured in years, 7, 8, 9, sometimes 10 years. It's awful. Whereas for a living donor transplant, the timing basically depends on making sure that the donor is healthy and able to go through the procedure safely, both in the short term and the long term. And therefore, it can be timed. The other thing, of course, is deceased donor transplant from a dead, but you never know when you're going to get it. You go on a list and you get called any time. So you kind of live, wondering when the next telephone call is coming. And that's very anxiety provoking. Whereas in living donor transplantation, you get a date. And we're going to do it on whatever, Monday or whatever. You have a date so you can prepare yourself physically and emotionally. But the event, it doesn't come as, oh my God, I got to run to the hospital now, because you know ahead of time and your family know ahead of time. And you can make both physical and practical and emotional preparations for it. Also, I should say, generally speaking, and this is a generalization, the outcomes of living donor transplantation tend to be better than those from deceased donor transplantation. In general, and I have to be very careful to say in general, kidney transplants from living people tend to live longer, tend to function longer than transplants from dead people. Now, that doesn't mean that any individual person necessarily it would be longer, but if you take groups of people, you can say that transplants from living donors tend to function longer than transplants from deceased donors. We will never do a transplant on someone unless we are convinced, as much as we can, that the outcome will be such that they will get a significant improvement in their quality of life and hopefully in their length of life. Although, for obvious reasons, we can never promise to an individual person, you are going to live longer with this. You can never say that to an individual, yes, you're going to live longer, because you never know what else is going to happen to him, to her, or any of us. But generally speaking, transplant will enhance people's lives. And most of the time, at least as a general rule, it prolongs people's lives too. But most important, I think people want quality. As a general rule, when you ask dialysis patients what they want quality, they want freedom, they want to feel normal. And that's what a transplant can do. It can make people back to normal again. Not totally normal, because they always have to take medications. They always have to see doctors. Life is not totally free. There are constraints. And so it's not a total freedom. And it's not free of anxiety. But it's a much better, it's a much better life. That's where we stand at the moment. You may be hearing in the news about all kinds of new developments of xenotransplants, that's transplants from animals and pigs and all kinds of things. And one of these days, that will probably happen. But I can tell you for the foreseeable future, transplants are going to have to come either from dead people or live people, from humans. And for the foreseeable future, patients are going to have to take a lot of medicines. Now, maybe one day out there, there'll be a way, and we're struggling to find ways that you may not need the medicines or so much medicines. And who knows, maybe one day, doctors will be able to go to the fridge and take out a kidney from a pig that's been modified and then plug it in. We're not there yet. And I think it's going to be multiple years before we're there. So I think we have to be realistic. I mean, you can be hopeful and optimistic as long as we can be realistic of what there is to expect in the future. So that's my introduction. I think that I suspect that anyone who's listening must have things on their mind. Otherwise, I suspect they wouldn't be here. So I'm very happy, and I think I prefer to do it this way, just to respond to you. Now, I have to say in advance, I can't respond to individual treatment issues. I can't get into precisely what medicines you need or that kind of thing. I can try to answer in a general sense. I can't answer specifically to a specific illness or specific clinical question. So I'd be very happy to answer your questions and tell me what's on your mind, please.
So perhaps I can just interject, Gabe, that might engender additional questions. One thing that comes up that we didn't discuss last time is the donor side of things. There's a lot of anxiety in donors. There's always the question of whether I can survive a normal life with normal kidney function with one kidney. What if I myself might need a donation in the future? And also, what's with the age? Is there an age limit to being a donor? Both at the extremes of age. Maybe if you could just focus for a short time on the donation side. Also, the issue of children giving to parents. They're often willingly happy to do so, but the parents go through a lot of guilt taking a kidney from their children. There's these types of issues also. So perhaps you could just focus on some of
Certainly,
you've had in your
certainly. So the process of preparing a potential person to be individual to be a living kidney donor is I like to say a clinical art form in itself, because the whole process is designed to protect the interests of the donor, and a donor, potential kidney donor, is regarded as a patient with the rights of a patient, just as the recipient is regarded as a patient and with the rights of a patient. So, first of all, the question, who can be a donor? So basically, a potential kidney donor has to be in tip-top health and have to be motivated to do it. These days, and let me just say this, they don't really have to be matched to you. So for a long time, for many years, the issue was whether a donor could be matched with a right blood group, were they, or all kinds of other things, were they matched to you? That was a big deal. Oh, am I matched to you? These days, let me just say this, and we can go with this again. We can overcome the matching issue by a variety of means, swapping and changing and all kinds of things that we can do. So the most important thing, a donor has to be in tip-top health and has to be highly motivated. And then the donor goes through a very careful, orchestrated evaluation process. So first of all, we do kind of routine screening to make sure the donor is healthy, obviously hasn't had cancer or hasn't had some horrible infection or is generally well, is not horribly obese or has awful psychiatric problems, all kinds of reasons that we would evaluate a patient preliminarily. And then after that preliminary evaluation, we then begin to do kind of routine blood tests and x-rays, kind of routine stuff. And then the donor gets a thorough education as to what's involved. The advantages, the wonder of being a donor, and also any risks that are associated with it. It's not risk-free, absolutely not risk-free. The risks are very small, but not risk-free. Any time that a doctor puts someone to sleep and uses a scalpel, there are risks, and that cannot go away. But the risks are very, very small, and they will be fully understood, both in the short term and in the long term. So education is a core principle, and also protection. That is, a donor might not want to decide to be a donor, but is afraid to tell the recipient that they don't want to do it. So, because privacy is so critical, if that happens, then the team will come up with a alibi to protect the privacy of the donor. We're not going to go to the recipient and say, "Oh no, your donor changed their mind." No, that doesn't happen. It does not happen. The privacy of the donor and the donor's decision process is absolutely protected. And so they don't have to worry that if they change their mind, oh, what are they going to say? How are they going to say? What are they going to do? That's protected, because that's our responsibility to protect them. As for ages, generally speaking, legally, a donor can be over the age of 18, although certainly you say in most centers, we much prefer donors to be in their 20s at the younger age, because for all kinds of reasons. And by the way, there are studies on brain development to suggest that the brain of a human being only really settles to its maturity in your early 20s. I think we would know that by, what it was like to be a teenager, etc. So by your early 20s, usually you are basically the person you're going to be. So without going into details of potential exceptions, we generally prefer people to be in their 20s. As for the upper limit, that varies. A lot depends. I think we all know this, that there are people of 70 who, when you look at them, think they're 60. And there are people of 60 who, when you look at them, you think they're 80. So we're more interested in what we call biologic age than in chronologic age. Round about the 70s is roughly where we begin to think, hey, no, maybe this is not a good idea. Also because, by the way, normally speaking, kidney function tends to deteriorate with age. So as we get older, in our 60s and 70s, our own kidney function in normal people tends to slow down a little bit. So I know at UCLA anyway, I think probably the oldest person we've used as a donor was 75 years old. And that's occasionally we do that. So that's roughly where, but I don't like to give firm guidelines because we try to individualize this a lot. Dr. Kurtz brought up the issue of parents being resistant to getting kidneys, living donors from their children. And because I live with this work, I put myself in that situation, imagine myself in that situation myself. So I would think if I had end-stage kidney disease, and I hope I won't, I've got kids that I love to pieces, and I think they love me back too. And if they offered me a kidney, I would lose some sleep. I would almost certainly shed a tear or so, or maybe more. But I would accept them, because I would accept their manifesting their love for me, allowing them to manifest their love for me, knowing that their rights and their health will be protected in the donor workup and preparation process.
Gabe, what if you had two children, each of equally as healthy, both of whom wanted to donate to you? How would you choose?
Well, generally speaking, so let me just add one thing, for instance. So sometimes I will find a parent who's reluctant to take a kidney from a child. And then I would say to them, tell me, you had a good relationship with your father or your mother? You loved them? Yes, of course I did. And if your father or mother would have had kidney disease, would you have given them a kidney? Of course I would. But then in that case, why don't you let your own child give to you? Oh, I hadn't thought about it that way. So sometimes I try to kind of turn it around, to look at it out, to turn it around. If there are more than one, then basically we allow the family to work it out themselves. We don't kind of pick and choose unless there's some medical reason why one. Sometimes there's a medical reason or a technical reason why one person might be a better match than another person, or a better reason for another person. But if it's identical and it could be any one of several people, then eventually we, have a family meeting and work it out. That's basically what we do. All this, we engage the patients. This is all shared with the patients and the family, so that they can have a sense of a free decision. A kidney transplant may not last forever. And in young people, particularly young people who have kidney disease, the likelihood is, even if they get a very good transplant, they may need another one in their lifespan. So sometimes what we do is look at a family and the ages of potential donors and think to yourself, well, there's a 50-year-old who probably won't be able to donate in 30 years' time. On the other hand, there's a 30-year-old who might be able to donate in 30 years' time. So we look at that family and say, hey, look, what makes sense for this young person in the long term? I call this family planning. We look at the family in the long term and say, hey, what makes sense for this person, not just the next 10 years, for the rest of their lives? This person's young, let's say he's 25, 26 years old. He's got hopefully 60 years ahead of him or her. how are we going to work this family or work with this family so that we can be the best, uh, um, do the best for them.
Wonderful. Okay. Does anyone have any questions for Dr. Danovitch based on what you've heard thus far, or any other questions you might have?
I have a question here, but it's not for the
Hello,
doctor.
what's your name?
This is David Marks.
Hi, David.
The kidney disease screening and awareness program at UCLA,
Uh-huh.
KDSAP, will be conducting a free screening on Saturday.
Okay.
If one normally gets an annual physical with a UCLA doctor, is it worthwhile to get the KDSAP screening in addition? Seems they do everything that an annual physical does, except for my annual physicals have not been doing a urinalysis. They
I
won't be
mean,
able.
I think that's for you to decide. I think if you're getting good care from your own doctor, I don't, not quite sure how to answer that because I'm not exactly sure what that program offers. I think the purpose of that program is the understanding that there is a lot uh, of unrecognized kidney disease in the general population. And I think the purpose of that program is to recognize address and determine and find out and look out for this unrecognized kidney disease in the general population so that we can get treatment for patients ahead of time. And by the way, the good news is that I would say, and I know Dr. Kurtz would agree, in the last 5 or 6 years, there have been dramatic changes, advances in the capacity to slow kidney disease, to slow the development of kidney disease and the progression of kidney disease. For years, really, things were stable. We didn't have anything new. But a lot of the new drugs you're hearing about in the news, these weight loss drugs, Wegovy and Farxiga, and all these drugs you hear about, every time you put on the television, they're advertising these medicines. It turns out a lot of these medicines actually have considerable benefit for kidney disease. And so now, in the last few years, we have a whole new class of medicines to slow the progression of kidney disease, which makes the recognition of early kidney disease all the more important because we may actually be able to do something, if not to stop it from progressing, to really slow it down from progressing.
Yes, I agree with everything Dr. Danovitch said. The program is really to identify patients that don't have a kidney doctor and have never had their kidney function assessed. So if you have a good doctor, there's really no need to go through this program. It's really for people that have not seen a kidney doctor before, or who don't know whether they have kidney abnormalities or not.
But just a regular physical exam, we'll check for that.
I, I mean, it's hard to know exactly what a regular physical exam, but yes, a regular physical exam, blood pressure check, diabetes check, blood tests, urine tests would check for that.
Okay.
Thank you.
Are there any other questions for Dr. Danovitch, or whether kidney
I do have
transplantation?
a question. He mentioned cancer would be a reason not to donate a kidney. Does it matter what kind of cancer? If it was a small cancer and they got rid of it?
Yes, again, it's hard to generalize. It's hard to generalize. So yes, as obviously there's cancer and cancer. There are people who there's serious breast cancer, or there are very mild forms of breast cancer. There are skin cancers that are really not problematic, but there are skin cancers like melanoma that are quite dangerous. So it's hard to generalize. Certainly, if someone's getting active treatment for cancer, that would be a problem. And or if someone was having a cancer that could recur, that would be an issue. But I think it's an individualized to know what exactly what the cancer is, what is its prognosis, is it likely to come back again, that kind of thing.
And as Dr. Danovitch has alluded to, I think in his previous talk, when you go on some of the drugs after the kidney transplant, it's not uncommon to have skin cancers come back if you've been in the sun. So you may not have had cancer before, but just after the kidney transplant, you may have something pop up that didn't happen before. Is that correct statement?
Yeah, of course. And of course, what we have, part of the workup of the donor is to ensure that there is no what we call transmitted cancer, that God forbid the donor has a cancer that they haven't recognized that could be transmitted to the recipient. That's why they undergo such a thorough workup to make sure that there's nothing hiding in there that could be a problem, not just for them, but for their recipient.
What
Great.
does that workup entail?
Again, I'm not sure we need to go into it in detail, but it's a blood test, X-rays, it's physical examination. I mean, CT scans, all these things that we go through, chest X-rays, cardiograms that we go through to evaluate the donor. So the donor gets by the way, one of the advantages being a potential kidney donor is you get one hell of a workup. You get one hell of an evaluation of your health. And there are times we pick up stuff. There are times we pick up stuff that someone wasn't aware of, and we've done them a big favor. And maybe as a result, they can't be a donor, but they're very glad that we found something. That's not uncommon because we put them through, a more thorough workup than you would go for your regular annual checkup. Much more thorough.
Any other questions for Dr. Danovitch? I'd like to focus maybe a couple of minutes on the psychiatric issues. I know you do a thorough psychiatric screen on the donor and the recipient, but the drugs that the recipient goes on, the prednisone, perhaps some of the other drugs, could bring out latent tendencies to. How often do you see de novo or unpredictable psychiatric abnormalities in the recipient, despite the fact that they've been worked up?
Not these days, not very frequently, because fortunately, the doses, the drug that always used to cause people, to be discombobulated, if I can use that word, was very high doses of prednisone, of steroids. And these days, we're not using those very high doses anymore. But we're on the watch out all the time for depression, for suicidality, for other psychiatric concerns, because people, it's very stressful, all of this. So we have support groups, we have psychiatrists and social workers and us doctors. I mean, that's what we attuned for, to help people with emotional problems after a transplant.
So it would be uncommon for a patient in the clinic to say to you, I just can't take all
No, very uncommon. Very uncommon. Very uncommon.
Back to dialysis.
No. Very, very uncommon. I mean, sometimes the course after a transplant can be very complicated, and patients can say, "Oh my God, what have I got myself into?" That's uncommon, but I can't say it never happens. Yes, it can happen, and part of the education process is for people to understand in their individual particular case what the risks of a negative outcome are. They're small, but they're there.
And how often do you see lack of compliance taking the medications? 2 or 3% of all the patients?
Well, a lot depends on age. So the term non-compliance, the term we prefer now is something called non-adherence. That is people who, for one reason or the other, forget to take their medicines or don't take their medicines or decide not to take their medicines. I mean, we drill into patients the importance of taking medicines. The group of patients that is at most danger of losing a transplant for not taking medicines are teenagers. And it's well known, young children who are unfortunate to have kidney disease, usually their parents are around to make sure they take their medicines. And by the time they reach teenagers, it's become part of their lives, something they do. But probably the group that's the greatest risk if someone in the age of 14 or 15 or 16 gets kidney disease and they have to take medicines and they all swell up and they get acne and they get this and like that and the hair. For teenagers, it's very hard, very hard. And they are really probably the highest risk group for non-compliance and depression and getting people through school and all of that stuff. So I spent my career dealing with adults, but as you know, at UCLA and other places, there are separate teams of pediatric transplant doctors whose job it is to look after the special needs of children, particularly teenagers.
And it's probably not surprising they're also the highest group for non-adherence on dialysis.
Right. Yeah. Yeah.
It's
It's very hard for
very
teenagers.
hard age group to treat.
Very hard. Very hard.
So what you're saying is if you can get them through the teenage years, by the time they come to you, there's
Yes, by the time they come to it. Yes, and most adults now, adults sometimes forget medicines, or sometimes say, well, maybe after a few years, maybe I don't need this stuff anymore. Don't do that. Don't do that. I mean, sometimes you can come and discuss with us, and we may be able to reduce the medicine doses and adapt them. We can do all kinds of things, but you have to do that in concert with your transplant doctor.
And what about
And then don't run out of medicine. We always tell people, have a stock in your house if there's an earthquake, if something, all kinds of things can happen. Always have a backup. Go on a trip, take enough with you in case the flight is delayed. All kinds of things like that. To think ahead, to have, to know, so that you're not in a situation. Oh my God, I don't have any. Oh, I run out. You don't want that.
And what do you do about the elderly, let's say people in their late 70s or 80s whose cognitive abilities are starting to change, and you assume that their social network was fine, but now it's changing more dynamically?
Well, it's hard. One of the things we make a big issue about in our preparation for transplant is the whole issue of caregiver. That is, transplant patients need to have a caregiver, need to have someone who is close to them, physically, emotionally, who can help them through this, particularly in the early stages. It's hard to go through illness alone, no matter what the illness is. Any illness, chronic illness, going through alone is very hard for anyone. Transplant patients is particularly important for them to have a support network, and that's why we have social workers who evaluate the support network. Because there's all kinds of things, traveling back and forth to clinic, whether you can drive or not drive, all kinds of things that we need to, the practical day-to-day issues of taking care of yourself.
And another group that comes to mind are people during their working years who might be doing a lot of traveling, maybe to foreign countries. How do you interact with, or perhaps you don't, with caregivers or nephrologists in other countries to make sure if they're away from you, let's say for 2-3 months and coming back, how do you ensure that the continuity of the care will be what you hope it will be?
Well, look, anyone who moves, people move addresses with the United States all the time, not only, so what we always ensure, or do our best to ensure, is there's a name and a human being at the other end that will take that person's care over. And that happens a lot when patients move around the country or move to abroad. We have to make sure they get the care. Absolutely. And so, I mean, it's all a matter of planning. That's why, to some extent, the life of a transplanted person is still not totally free, because they have to always think ahead. What if I do this, if I run out of medicines, what am I going to do? Who's the doctor going to be? Where am I going to go? So you just have to have a different mindset.
And conversely, how often is it you'll get a new patient who perhaps started off in another country or another part of the States, who you felt was a disaster, who was medically in really bad shape because of the care they got elsewhere, independent of...
Well, most of the time, at least in the United States, transplant, first of all, I should say, to tell everyone here, transplant programs in the United States are monitored, and transplantation is monitored through the government, through something called the Organ Procurement and Transplantation Network, which is part of HHS. That's the Health and Human Services of the United States government. Transplantation is monitored more than any other medical condition. Transplantation is monitored very carefully, and every transplant program has to have very high standards. We're constantly audited. Nothing we do is not available, in a computer to follow up on. Everything has to be recorded and it's down. You can look up the outcomes of in any transplant program in the country you go to. So in the United States, I can't vouch for every single person everywhere, but in the United States, I can say that the quality of the transplant programs is very high.
And from other countries if they got a transplant?
I think people coming from from Europe and the developed world, certainly yes. People coming from the undeveloped world, they can bring with them sometimes infections. It can be quite difficult.
Thanks, Gabe. Any other questions from those on the call for Dr. Danovitch? No? Okay, then I think we'll stop a little earlier than normal. And Dr. Danovitch, thank you very much
My
again.
pleasure.
As usual, a
And if
fascinating.
there are any questions that feel you feel you don't want to ask in public, I think probably Leslie can come
Yeah,
up with a mechanism by which you could ask them separately, and then I'll do my best to address them. How's
yes,
that?
we have such a mechanism. Please just email Leslie, and she'll put you in contact with Dr. Danovitch, who, to the extent he can, he'll address your questions.
Okay. Thank you very much, guys. All the very best to you. Wish you well. Thank you.
Thanks for joining.